Thank you, ma'am. Thank you for the introduction. Uh, and
to
to
share?
see you once again virtually. Yeah, if Sangeet could share.
Yes, yes. If
Yeah.
whatever you want to do, we can do. If you're okay,
Okay.
if we share the presentation,
Yeah. That.
okay, then go ahead. PPT to Sangeet.
Yeah, just a second.
No worries. Please send it and we
Sangeet,
can.
you have. Yeah.
Just couple of minutes. We have one question. Go ahead, Mukta.
Yeah. Sangeet, next slide. Yeah. Okay. So, sorry for the delay from my end. I'll just quickly jump into the topic because we have to wind up and we have a case presentation afterwards. Um, so I just wanted to ask everyone, why are we talking about communication? What do you think? If you could unmute and tell me, or if you could type in the chat box about why you think we need to learn and talk and discuss about communication in the context of palliative caring. Anyone? To give information. Okay. Uh, okay, to deal with patients with more fear and anxiety. All right. Understand better. Yes, absolutely. Okay. So I think we have a few responses here, and they're all right responses. Basically, research studies have shown that there's a major unmet need for communication. Communication about information about the disease, about the prognosis, about treatment options, intent, side effects, complications, a lot of things. Basically, what all these studies tell us is that we avoid difficult conversations in our profession, okay, as medical practitioners. Probably because we don't know how to have these conversations, which is precisely why we're here today and having this session. All right. Next slide. So, why do we need to have good clinical communication? Like many of us have already responded in the chat box, good clinical communication enables a lot of things. It helps the patients to express their needs very easily and efficiently. It helps clarify doubts, baseless assumptions. Mm, uh, and it doesn't, it's not only about the patient, it's also about me, right? I can't assume what my patient needs. I need to know what they think, and that is why I need good clinical communication. It will help me build with them. It'll aid in treatment adherence, and it'll definitely help patients and families deal better with the emotional responses to the illness and the uncertainty which the illness brings. It, like somebody already mentioned, it helps us gain more knowledge, know more about what's happening. It enables us to better understand the symptoms, about how are these symptoms changing, how is that change impacting the patient's quality of life. Simply put, we start seeing very clearly exactly where our patient stands physically, emotionally, spiritually, mentally. Right? Basically, it gives us clarity about the clinical condition and helps us better understand what is the patient's thought process, the meaning that the patient is attaching to his or her situation. And through good communication, as physicians or basically the entire medical team can convey the required information about the disease, about the plan of care to the patient in a manner which will help them feel supported, right? Another thing why good clinical communication is important and it can enable is basically these are long-term clinical relationships that we are talking about, which are sustained on trust. And communication is going to help build that trust. And when there is mutual trust among members of this team, including the patient, the family, and members of the treating team, it is definitely going to encourage shared decision making and rational decision making about treatment, right? And the patient is then more likely to complete the prescribed therapeutic plan and to adopt more health promoting behaviors because their needs and their priorities have also been taken into consideration. So basically, it will allow a balanced decision to evolve based on patients' values, beliefs, priorities, and also at the same time supported by clinical evidence and rationale. It's not we taking the decision for them, right? Which is what good clinical communication will enable us to do. Next slide. Okay, so here I'd like to share a story of one of my patients, and I tell the story in every single communication session that I take because the crux of this case was always communication throughout. So I don't think there's anything better than this patient story to illustrate how communication is an essential component of our work. So here we are talking about a 37-year-old lady coming family, a poor socioeconomic status, educated up to 10th standard. She stays with her husband and her 12-year-old son. They live on a farm where her husband works as a caretaker of that farm. And she's unable to understand English. She follows Hindi, but she's not very fluent at it. Given that they come from a rural background, the socioeconomic conditions, lack of literacy, lack of exposure to cities, they are quite hesitant, both the husband and the wife are quite hesitant when it comes to going to big institutions, big hospitals, where they feel they won't be entertained or that they'll ask obvious questions, end up looking like a fool, or they won't understand what the doctor is telling them anyways. So that is the background, basically. They've never had to go to such a place also because they've been quite fit until now. They're quite young also. And whatever little health issues they've had so far, they've managed with the PHC in that village itself. And what happened was, out of the blue, this lady was diagnosed with a shocking case of kidney failure. So basically what happened was she went to the PHC with certain complaints, tiredness, swelling of feet, all of that. And they urgently sent her to the big government hospital in the capital city, around 3 hours from their place. And the doctors at the PHC didn't want to deliver the news. They kept mum, but they asked her to rush and do the tests and show the doctor over there. And so what happened was, their boss, the owner of that farm, took matters in his own hand. He accompanied them to a specialist. This specialist did not speak the regional language. Whatever he spoke was either in English or Hindi. It was directed at the patient's boss because he would understand. And the husband, who was intimidated by the entire setup and the doctor and the reports, which were obviously in English, started pushing the boss ahead whenever it was time for discussions with the doctor, assuming that if he goes all by himself, he might misunderstand or he might panic. The patient was not told anything about the diagnosis except that her kidney was not functioning properly. Her treatment began, but there were no results. And when they went to the doctor with the next follow-up reports, he just turned to the couple and he very curtly told them that, next time when you come, get your parents for organ donation. And the patient found this to be very rude, very insensitive, obviously. And she refused to visit him again. And then she was taken to a different doctor who would also not communicate directly with her, but at least he was not rude. And the husband, with his prime defense mechanism of avoidance, he got her everything. He got her medicines, got her good food, fruits, fresh vegetables, all of that. But he never spoke to her about her illness. The only time he spoke about that illness was when he got angry at her because she was not taking her medications. And he complained about the same thing, about lack of adherence to treatment, to his boss, the owner of the farm. And that is how I got into the picture, because that the owner of that farm contacted me and said that they would like me to talk to her. And now, okay, so based on what we know about S, do we all agree that what was happening until now was poor communication? Yes. Sangeet, next slide. Okay, what could have been the consequences of this? We agree that it was poor communication. What do you think would be the consequence of this poor communication in her case specifically? Do you think the fact that she was not taking medications could be due to the poor communication? Any other problems that you see which could have happened because of the poor communication? Patient might have stopped coming back to appointments. Absolutely. Increased anxiety. Could the family conflicts uh, be due to poor communication? Yes, absolutely. So, next slide. Right. So let's just look at what are consequences of poor communication in general, and you would see that a lot of these are also present in this patient of mine. Firstly, it may lead to poor symptom control. Yeah, because there is lack of compliance with the plan of care, because the patient's needs or concerns or agendas have not been discussed and have not been addressed at all, which was what was happening with her. There is poor adjustment to illness and interventions, which can lead to worsening of distress. In her case, she was confused. She was quite scared of the uncertainty when I met her. Conflicts can escalate. Conflicts between the treating team and the patient, between the patient and the patient's family. So all these different kinds of conflicts can start and can escalate definitely because of poor communication. They can impact the therapeutic relationship definitely. Like I already mentioned, she just stopped going to that doctor after she found him to be dismissive. Uh, and of course, medico-legal problems will stem primarily from poor communication and misperceptions and misunderstandings that ensue out of it. Uh, so basically, now we know that something positive comes out of good communication, and there are negative consequences of poor communication, right? Uh, and there are some people, Sangeet, next slide. There are some people who feel that they are good communicators because they're quite sociable and they like to talk. Yeah. So, do you think that's enough? Just being able to hold conversations is not necessarily good communication. Yeah. One-sided communication, just being gentle with a patient, this does not mean that you're a good communicator. So what is not communication skill? Like I said, conversation is not necessarily adequate clinical communication. A good conversation, yeah, somebody, Dr. Madhuri is saying in a way that patients understand, right? So just a good conversation on general topics, travel, politics, weather, that's not adequate clinical communication. Trying to convince the patient to follow an agenda, which we have decided for them, that's not good communication, right? And nor is it all only also only enough that we are being very soothing, very gentle, but again not allowing for the patient's participation in the decision making, or even to share what they are going through. That's again not good communication. Next slide. So as professionals, one very important thing we need to understand is these skills are not inborn. Nobody is born being a great communicator. So, but that basically means that this is good news because we can all learn. It's a skill. It can be learned. And we can keep getting better at it. And yet we don't many a times do it. Definitely not very proactively, not actually looking for ways to become better communicators. So why is that? What stops us? And what stops our patients? It's not a one-way street, like I said. It's not just us being good at communication. Our patients also need to be able to communicate things to us. So what is it that's stopping us? What are the barriers that we are facing? Let us just look at that. Next slide. Right. So why don't we put efforts into becoming better at communication? This is something I think we can all relate to this. We've all had times when we have felt at least one of these things. One is we are too busy to spend time to understand patients' thoughts and feelings and sit by their bedside and chat with them. We could also be worried about upsetting the patient and handling reactions. So, it's better to just avoid talking about difficult things at times. We might not have the knowledge and the skill to actually touch upon certain topics which can make us uncomfortable. So it's an unpracticed area of interaction for us. We might not be able to say, I don't know, to certain questions that the patients ask, which is also why we might avoid certain conversations with them, especially when there is a lot of uncertainty about what's going to happen. Concentrating on physical concerns, we spend a lot of time concentrating on physical concerns, right? That's just easier for us as doctors. We might not perceive communication as a part of our job at times. We might be worried about being blamed. We might fear that the situation might worsen, which is something which, in recent times, I think this fear has increased because of a lot of different incidences which we have seen happen all over the country, where doctors are being increasingly blamed, where situations are escalating, conflicts are escalating. So we might be worried about that. And a very practical problem of being unfamiliar with the language or the dialect. And that can be a big barrier. Next slide. So, and why doesn't the patient communicate at times? There are barriers that they face as well. So, and the most obvious one being that the doctor is so busy, why to disturb? Yeah. So the physician is perceived as being too busy. There is lack of privacy, unfamiliarity with the surroundings, especially if they are in a ward, like a common, they don't have a separate room where there is lack of privacy to talk to a doctor about their innermost fears. There is also this perception that I can only convey physical problems to my doctor, right? They feel that all other issues are irrelevant. There is fear of confirmation of bad news. What if I'm really going to die? Yeah, nobody would want to hear that. There is also fear of treatment being denied if they raise questions or doubts, especially if they're seeing doctors as a very, sort of an authority figure. There is fear of losing control over emotions when they talk about difficult things. Many times they're stumped by medical jargon, by technical terms, and they don't clarify. And of course, there is a hierarchy of the hospital environment. Usually, not everybody from the treating team is easily accessible to the patient. And you might notice that so many of these things were present in my patient also. Yeah. Next slide. So why we're speaking about the barriers first before we talk about how to communicate is mainly so that we can start identifying these barriers in our settings, wherever we work, And when we start identifying these, only then can we rectify them. And only when we rectify them, there is otherwise, however many communication skills we might learn, we would still not be able to have good clinical communication if these barriers still exist. So let's turn to the skills per se. Next slide, Sangeet. Yeah, okay, thank you. Basically, communication includes acknowledging, understanding the patient's concern, the family's concern, responding in the most appropriate manner to bring clarity to their current situation, right? So we take in information, verbal as well as non-verbal. We are actively, mindfully present and receptive to what's happening. And then we also respond appropriately, again, verbally and non-verbally. Here on the slide, what you can see is what we may call the 4 principles of good clinical communication. And you might notice that it has got very little to do with your language usage, very much to do with just being a good human being. And that is the prerequisite of being a good communicator, if I may say so, especially in palliative care. So the core principles: respect, family with respect, essential for a healthy relationship, which in turn is going to promote good communication. Empathy, the ability to try and understand another person's feelings, placing yourself in their shoes. It always helps to acknowledge the other person's suffering. It helps to build a good relationship again. Very different from sympathy, which I think most of you would already know that there is a very big difference between empathy and sympathy, where sympathy is just a sense of pity, which your patients might find offensive. Third thing is trust. Once the patient loses trust in you, you lose the ability to help them. Yeah. So truth is essential. Truthful communication, honest communication to maintain trust. Lies, for example, in an effort to conceal the diagnosis, etc., that's going to destroy trust and destroy your entire therapeutic relationship. And lastly, unconditional positive regard, where we as the treating team have no right to be judgmental to our patients, whether the patient is being a good patient or a bad patient, thankful or grumbling, optimistic, pessimistic. We should try to consider that person as the most important person in the room for us. In particular, we should make sure that we are not taking sides and that we are wholly, unconditionally accepting the patient as they are. Yeah. Next slide. Okay, here is a quick question for everyone. Let us say you're taking rounds, you meet a patient and they're telling you that there are so many thoughts that I can't sleep at night. Okay. And so which of these options would you choose? Or which of these options do you think reflects the core principles of good clinical communication? What would you want to say to this patient who is saying that they are having so many thoughts that they can't sleep? Okay. Somebody is saying B. Okay, great. I think most people have said D. There's just one or two who. Okay. Okay. All right. Great. So just to clarify, for those people who thought that B is the correct answer, when you're saying, oh, don't worry, it'll be all right, you're basically dismissing their emotions. You're invalidating what they are feeling, and that is going to create a block. They're not going to share what they are feeling with you, if that is how you respond. Right? But if you validate that, if you take into consideration and acknowledge what they're going through, definitely there's going to be more coming. They're going to feel that you're accessible. They're going to openly share what's happening with them, and only that is going to help you treat them. All right, I hope that is clear. If it's not, we can address it. I think we have some time for question and answers later on. So, all right, going ahead. Okay, so let's look into a little more details of what communication skills are. And so we all know that there are these two types. There is verbal communication, there is non-verbal communication. Both are equally important, definitely. Verbal is basically everything that you are expressing using language. Non-verbal is your facial expressions, your body language, gestures, all of that. We definitely know that communication occurs in both these channels, through verbal as well as non-verbal channels. Sometimes we are unaware, though, that the bulk of our daily communication is non-verbal communication, not verbal communication. Okay. Sometimes, especially in younger children, in people who are terminally ill, differently abled, even emotionally overwhelmed for that matter, non-verbal communication can become the sole means of communication. We also rely more, or we basically trust the non-verbal communication more than the verbal communication, right? What I mean by that is, if I was sitting in a room and you were to come in, and I would just look at you, frown, and say hi, yeah, versus if you were to come in and I would smile and say hi, where would you feel that I was actually welcoming you? I was actually saying hi. The one where I was smiling, quite sure, right? And that's because you took into consideration, or you trusted the non-verbal rather than the verbal. So whenever there is a discrepancy between the verbal and the non-verbal, we trust what is not said rather than what was said. So it is very important for us to pay attention to and process and tap into the non-verbal along with the verbal, right? So let's say, for example, I'm taking rounds and I'm talking to a patient, and the patient is looking quite gloomy. But when I ask them, how are you? They say, oh, fine. I need to acknowledge that they're not sounding very fine to me and that they're sounding gloomy. So we have to respond to what they haven't said but have expressed through non-verbal channels of communication. Right. And and just like we speak about the patient's non-verbal communication, we also need to be aware that we are communicating so much through our gestures, postures, how we sit, the tone of our speech. Am I looking at them when I'm talking? Where am I sitting? Am I leaning towards them, away from them? All these things are going to matter. Right? So we need to be aware of what messages we are sending to our patients. For example, let us say I'm talking to a person who's crying, okay, and I'm sitting there, but I'm constantly fidgeting, okay, like I'm tapping my feet, or because I'm thinking that, oh, because I'm talking to them now, I'm going to be late to pick up my kid from school, and I'm discreetly like checking my watch, very restless. Don't you think the patient is going to notice that, and that's going to create a block in the communication, right? So whenever you're there, whatever time that you're giving them, make sure that you're aware of what non-verbal messages you're sending in that time. Otherwise, that communication is not going to be effective or efficient in any way. Next slide. Okay. So there are simple things about our body language that facilitate communication, right? Just a genuine smile, having an open posture rather than, sitting like closed, where it looks like there is an invisible wall between you and them. Looking at computer screens and typing away when the patient is telling you something, appearing super busy, checking the notes when the patient is talking to you, uh, begin questioning even before looking at the patient once, even before greeting them. All these things are going to again matter when it comes to either facilitating or creating a block in communication. Going to their eye level, especially when it's children, going to their eye level and talking to them. Very simple things, but they make it a lot easier for you to communicate what you're saying because they indicate respect, right? And they communicate that you have a genuine interest in being here with the patient. So let's also look at some helpful strategies that you can use when you communicate, right? Firstly, open-ended questions. This is your best friend, okay? What I mean by open-ended questions, can anyone give an example of an open-ended question versus a close-ended question? Any idea? Okay, if not, I'll just, so let's say, for example, asking, how are you doing today? Now that's an open-ended question, yeah? Versus asking, are you in pain today? Yeah, that's a yes or no question. That's a close-ended question. Open-ended questions, was someone saying something? Okay, yeah, I can see some responses. How can I help you? How are you feeling today? Absolutely. So basically, open-ended questions invite the patient to open up, to express. They give you more information. They let the patient direct the conversation to what the patient feels is a priority concern for them. And this is important for us also because otherwise we risk losing out on important information that we didn't inquire about if we are sticking to close-ended questions. So make sure that you always begin conversations with open-ended questions. Let the patient lead the way to what they want to talk about. Secondly, always summarize and always check for patient's understanding. Whenever you're talking to them, is there a discrepancy between what you wanted to convey and what the patient has understood? Yeah, and it's also always useful to summarize the discussion so that you can reinforce joint decision making. You can give the patient a chance to get everything in a nutshell. In case, especially if in case they felt information overload in any way. Okay, so say something like, I just want to go over what we've been talking about so that we're on the same page. So whenever you're ending a conversation, always ask what questions do they have? Is there something that they would like to know more about? So all these things, basically about summarizing and checking for their understanding. After which you would give them a summary. Like, I would like to go through the key points of whatever that we have discussed. And then arrange for a follow-up. Say that we'll meet again. And in between also, if there is something that you come up with, any questions about what we've spoken, anything you want to discuss, please note them down and we can speak about it in our next meeting. Thirdly, avoid jargon and avoid overload. Whenever you're giving information, don't use heavy technical medical terms that the patient is not going to understand. Keep it simple and keep it short, to the point. Okay, remember that our goal is that the patient understands what we are saying. Don't give too much information at one time. Especially because this is heavy information that we are giving, emotionally loaded for the patient. So it's always good to give it in like steps rather than throwing it all at once at them. Fourth is encourage them. Always encourage them to ask doubts, ask questions. But at the same time, respect the patient's choice about the extent to which they want to know. It's their right to know, but it is not compulsory that they should know certain things, right? So it isn't compulsory for you to tell them everything, even when they've explicitly stated that they don't want to talk about it right now. Like I already mentioned, most of these discussions have a heavy involvement of an emotional component. So make sure you don't avoid facing these emotions. Okay. So always acknowledge these emotions, be present mindfully whenever there is an emotionally overwhelming moment for them. What I mean by mindfully is in the here and now without judgment, and listen actively, acknowledge what they are feeling, let them know that it's okay to feel what they feel and that it's also natural in the given context. Don't invalidate, right? So let's say, for example, me saying there is nothing to be afraid of is a strict no-no because I'm basically lying. Yeah, especially in the palliative care setting. Next is be okay with silences. They help. Learning to not be uncomfortable with silences, letting the patient take their time to process is very important. So if you've told them something and they're just silent, okay, they're just taking things in and they're processing things, don't fill that silence with pointless communication. I'm saying pointless because it's often not heard or received. The patient is busy processing what you've just said. Or if it is actually heard, then we have just distracted the patient from actually processing the information and emotions and organizing their thoughts before they respond. So don't interrupt that process. If there is silence, be okay with that silence. Um, then there is the question of hope versus truth. Okay. Now, whenever we are delivering bad news, we can definitely do it with sensitivity. It doesn't have to be either hope or truth. We can find a balance between the two. So to give you an example, mm, I need not say we can't do anything more. There is no cure for your disease. So there's no point in continuing to stay in the hospital. You'll only waste your money. That's probably truth, but not very hopeful. I also need not say if you believe and have faith, you'll surely recover. That's hopeful, but not truth. Instead, I could give them a balance of the two. So I could say something like, sorry, I'm afraid there is no more treatment, curative treatment available for your disease, but we can definitely keep you comfortable with medications and regular monitoring, and we are always here for you and we'll do our best. Yeah. Now that's hopeful, but that's also true. Next is confidentiality, reassuring the patient that sensitive details that they might not want to disclose are completely confidential so that you encourage them to talk about certain things which are sensitive for them. Respecting their boundaries about what they want to tell, what they don't want to tell, all of that. And further inquiry, especially in problem behaviors, further inquiry is something that we often don't do, but it's quite a helpful strategy to use. Especially when, what I mean by problem behaviors is, let us say a patient is not eating or a patient is having social withdrawal. They're not talking to anyone who comes to visit, or there is non-compliance to medication. Now, we only look at the what of the problem behavior instead of the why. Usually, there is always a deeper underlying reason to this problem behavior. So always ask why they're doing what they're doing, and ask with curiosity, not with judgment. Don't ask in a scolding sort of tone that, why not taking your medications? Not like that. So to sum all these things up, all these strategies, to put them in a nutshell, you start with open-ended questions. You let them lead the way. You speak simply, validate their feelings, adhere to the core principles, and ended by summarizing all that you've discussed. Make sure the doubts are answered, ensure a follow. Right? Hope that's clear. So moving on, Sangeet, next slide. Yeah. So we have seen what to do. Let's also see what not to do, because that's equally important. Do not moralize or philosophize. What I mean by that is, don't say things like, this life is a gift from God, how can you think of dying? Those kinds of messages, don't use them. Avoid comparisons. You might use them in a, sort of, your intention might be to motivate a patient, but usually that doesn't work. So avoid comparisons. What I mean is, don't say things like, look at that patient, they are also in so much pain. They're younger than you, but look whether they are crying, why are you cribbing so much? There are others in a worse condition than you should thank God. Those kinds of things is what I mean by comparisons. Yeah. Don't use meaningless statements which can stop further communication. Okay. Which is, I've already mentioned it twice, I think. saying things like there is nothing to be afraid of. This will just block the communication then and there. So don't use that. Don't use jargon. Uh, so instead of saying the carcinoma is radiosensitive and it increases chances of remission, say it in a simpler way. Use layman terms. Don't use terms like metastasis. Just say spread. Yeah. Say, talk in a way that they'll understand. Don't give false reassurances. Don't make assumptions. Always ask what made them ask something. Inquire further. Don't be condescending. Uh, so don't have that higher up attitude where like more than the doctor kind of. Don't have that kind of attitude. Don't force your beliefs onto the patient. Maybe religious beliefs or otherwise. Don't, because they're your beliefs. The patient is going to have their own belief systems. Let them use that belief system to feel better. Sympathy is a strict no pitying them, no saying, oh, poor you, so sad. No. Don't use, on the other hand, no inappropriate humor also, saying things like, oh, you want the final visa award, stuff like that, to lighten the situation or whatever. Don't use that. And like I already mentioned again, a balance between honesty and hope. So the thoughtless honesty has to be avoided, where it's important that you're honest with your patient, but it's not just what you're saying. It also is important about how and when you're saying what you're saying. Yeah. So don't be thoughtlessly honest. Make sure you give them the right information at the right time and in the right way. And lies again are a strict no. So because they'll break trust. And like I said, if there is no trust, there is no way that you can help a particular person. Next slide. Okay. So let's just put things in a sequence so that it's easier to put into practice. Okay. So if we had to look at steps of effective communication, this is what it would look like. Firstly, you would build a relationship. Yeah. You would take your time. You would have some privacy. You would set the scene. You would preferably use all these strategies, not to go in their space, but close enough to uh, be there with them in that moment. You convey empathy with your expression, with the words that you use. Basically, very important that you convey that you care, which is how you will build a therapeutic relationship. So that's the first thing you'll do. After that, in the communication, you will open up the discussion. You will acknowledge feelings. Yeah. When you're opening up the discussion, you will acknowledge their pain, their loss, the suffering, basically, which will make the patient feel that he or she is understood. Unlike dismissal of these emotions, you listen actively to what they are saying. Active listening will involve eye contact, appropriate facial expressions, which will show empathy, body language, like, at times leaning forward or that kind of a body language, which is more receptive, and verbal response, yes, see, or asking questions in between, all these small things, which will encourage the patient. Yeah. Or you could paraphrase, you could repeat the last few words so that you encourage them to talk more. And you listen to what is said, but also to what is not said, specifically their facial expressions and body language, which might indicate suffering, and especially if there is a discrepancy between the words that they are, like what they're speaking and how they actually look. So that all of this will happen when you open up the discussion, after which you'll gather information. So you'll explore, you'll find what is the patient's level of understanding, what do they know, how much do they want to know. Again, using open-ended questions here will help. Statements which will invite responses. So asking how you could help them, asking what do they think might be the problem, what worries them the most. These kinds of things will help you gather information first, which will help you understand the patient's perspective. What does the patient feel about the information that they have? Do they have any questions? Here, always be prepared for an emotional reaction, sobbing, anger, emotions that can occur. Sometimes you might need to facilitate sharing here, where you would have to ask specifically whether they can tell you what they are thinking, what are their thoughts about this, how are they feeling about this, because they might, like I already mentioned, one of the barriers to communication is this preconceived assumption that I can only talk about my physical problems to the doctor, not about my thoughts and feelings. So you might have to actually facilitate sharing by asking this. Yeah. Only then you'll understand what is their perspective. And only after all of this is done, you start sharing information. So always ask before you tell. So share information where let the patient decide the agenda for further discussion. In other words, what they consider important has to be discussed. If they want to postpone discussion about certain things, about further treatment, it should be allowed within a reasonable time frame. So don't press them, especially if you have got a little time on hand. Like I also said before, the patient has a right to know everything, but not a duty to know everything. So confirm what the patient really wants to know. How much do they want to know? Do they want to postpone a discussion about certain things for later? And only then you share information. When you're sharing, use common conversational language and check understanding at every stage. After you've shared information, you reach an agreement on problems and plans. You summarize what are the problems that the patient has spoken about. You suggest a course of action, answer whatever questions they have. And finally, you arrive at a course of action which is acceptable to the patient. And you make it clear that this is not an ironclad contract. This is not a hard and fast law or rule. And these plans are negotiable at any point, right? And then you close the discussion very sensitively, not abruptly. You review, you summarize the discussion before you finish, and you always leave the door open to talk again. Arrange for a follow. Yeah, so these are basically the 7 steps of effective communication in a clinical setting. And after all of this, finally coming back to my patient, the story of my patient, which I was telling you, if anybody is wondering what happened to her, when I visited her, this is exactly what I did. These 7 steps which I just spoke about. Yeah. I built a rapport. I introduced myself. I told her I'd come to speak to her about her illness, to know how she was doing. And the moment she realized that I was not there with an agenda, make her do something, and I was here to just know how she was doing and what she was going through, with genuine concern about how she was coping, she opened up. The first thing that this lady told me was, when she had gone to this doctor for the first time, that was the first time in her life that she had heard the word kidney. She had no clue what a kidney was, what it did. Basically, when she was told that her kidney is not functioning, it was all alien to her. Okay? It had no meaning. But she did sense the seriousness in the atmosphere, the urgency with which the doctors were talking. She came home and she took her 12-year-old son's help, who was 11 at the time, and they Googled kidney. Okay. And so she understood a little bit about what it was, but not completely, definitely. And because it was Google, there was a lot of misinformation, obviously. People who could communicate the right information to her were mom. They were not talking to her. The doctor was not speaking with her. But there was no shortage of people with baseless information, all sorts of relatives, neighbors, friends, this and that, who had no forms or questions about whether what they're saying is true and how will it impact her. Okay, so she heard all kinds of scary and very tragic stories about how kidney failure it means that she's going to die. All sorts of scary stories filled with negativity and despair. Okay, and she did her best not to listen to them. Okay, and what I mean by that is, in an attempt to cope with all of that, she overcompensated by denying the seriousness of what had happened. She was tired of the 30 pills that she had to swallow every day. She had tons of questions, no one to answer them. So she stopped taking medications, which is how I came into the picture. And all of this I came to know when she started speaking with me. So we started right at the beginning with what is a kidney, what it does. Most importantly, that there are two kidneys. Okay. And we can function with one. Because she came with an assumption that what the doctor had meant, that her parents will have to give her a kidney. She basically felt that she was asking her parents to sacrifice their lives by asking them to give her their kidney. Yeah. So all of this was clarified. She cried. She let things out. She asked all the questions. She expressed her needs of how uncertainty was just bringing fear, how anxious and worried she is for her son, who has grown up too soon in all this ordeal. And if she were to know what was going to happen, what the doctors were doing, she would be much better prepared. She knew what she wanted. Clear communication. Yeah. That was the only thing she was expecting. Knowing what had happened to her, knowing what was being done to her, knowing what could happen to her. Very simple needs. And at the end of the first session, I did tell her that she was free to get in touch if at all she had any doubts at a later point as well. After the first consultation, she became much more cheerful. She started expressing more openly to everyone. The communication at home with her husband improved. They began speaking about what she was going through. We began meeting her son periodically also, which eased a big load off of her shoulders. That was one of her requests, that we look after her son in all of this, his emotional needs. She began actively working towards treatment. She took the initiative to tell her family about the transplant and about the related issues, which she had not done until then because she didn't know what to tell them. So, and she requested us to be there. So I met her family along with her. We went to their place. It's quite a rural area where there is like not even proper roads and all of that. So we went to their place. We had a meeting. We explained it in very simple terms to her family as well, to her parents, her brother. And we spoke about what treatment options were available. And then her father, who himself was in excellent health, he came forward as a donor after they discussed. I mean, this was not immediately, of course. We gave them time. They had family discussions, internal discussions amongst themselves. And then in a few days, they came and told us that the father was ready to become a donor. Mm. Of course, there were other complications post that as well, where she started having cardiac issues and a lot of things basically that she went through. But in all of this, she didn't lose hope because she knew what was happening. At every step, she was told what was happening. She knew what was happening, why it was happening, and what she was supposed to do, what the treating team was doing. So she continues, to date, she continues taking her medications and she takes them with courage and hope. Emotionally, definitely, today, she is fine. Physically, there is still uncertainty, but she's in a state where she can cope up with it, mainly because there are open communication channels right now. Which is why I wanted to talk about her story, basically, today. And that brings me to a close. If there are any questions, we can definitely address those now.
Thank you very, very much, Muktha. As we have been always telling, it is important to know that first it is a skill which can be developed, and no need to think too much about it. These
Yeah.
sessions are mainly for everyone to get that feel first, because this is also one of the important queries which all of you, whenever we have case discussions, we have one of the thing. Does the patient need to know? How am I going to tell? It is important. All these things, this non-verbal, no, has such an important role, which you might have been doing just, see, many times, no, doing something simultaneously. Nowadays, everyone wants electronic record. Okay. So that also we have to do. But how can I do that in a way that my patient is not going to be offended by that? So that is what we are trying to incorporate that into our own way of doing. Still do that, still care for patients, so we can do it. So everything is so important. And then another important thing, what I felt from thing was sometimes no this false assurance can be taken in different ways. One thing is sometimes the patient may be thinking that we are ignoring, as Muktha said during the presentation. So that also has to be given equal value and weightage. Because if the patient is thinking like that, finally patient is not going to tell, and we are going to be the loser. Patient also is going to be the loser, not getting what she could get, he or she. So everything is so, so important. And Mukta has taken you through nearly in such a way, like in a methodical manner, like the do's, don'ts, then also what you do, how to do it. So there is one question there. In case of language barrier, the translator may not have the necessary skills. How to manage the same? You want to go ahead, Mukta? You can tell, then I will also add on what I can.
That is definitely a very practical difficulty. I have personally faced this. I'm Goan and I trained in Amrita. So that definitely was an issue for me. By the end of it, I learned Malayalam. But on a serious note, when there are, especially when it happened with, Arab patients from the Gulf, where there was no way to, we had to use a translator. And it is quite difficult, especially when you have to, when there is emotional, when you have to communicate things like empathy. Technical things, it's still a bit easier to communicate, I feel, but not. I think that is where I feel the non-verbal comes into picture many a times. It's just the patient. I have had experiences where they didn't need to actually understand the words. They just had to look at me and know that I was on their team. And that itself gave them so much hope, and but I mean, of course, it's not. See, it's not going to be perfect communication in such cases. There are going to be uh, flaws. There are going to be things we could have done better. I think it's just about taking all of that into consideration and doing our best with the limitations. If ma'am could add more about.
Yes, totally true. See, first, as you said, no, positives first. The thing is that it is not easy, it is a challenge. But again, you can see how you can do. So, first, you can have a chat with the translator. As Mukta said, no, I have also had these things when I have had to work in different places with different languages. So few things is like you can speak to the you have the translator whom you have, because internationally having worked, I have had these personal experiences. Yeah, like when you get people who don't understand, because it is a challenge, but at the same time, so if you talk to the translator first and convey what you want to do, it there you need bit more time. Okay, so that is one option. Next is the verbal cues. what we say, do have a very, very big role. See, in today's talk itself, you saw a verbal, how much percentage it was, tone, non-verbal, what percentage it is. I'm going to give you a small, simple example which all of you face on a day-to-day basis. Either with any of your kith or kin, family, husband, wife, son, daughter, brother, sister, something you tell. Okay, what do they pick up? You told it in that tone. You told it with a grudge. You told me what I said is not is important for whether it's being done or not. So even in our day-to-day activities, the non-verbal has a very big role. So use that at this point of time and use the translator in whatever way you can do. And next, if you are really interested and want to do, pick up few things which are important in that language. Wherever you're going to go work or something, learn some things very basic which you need. For example, when you're communicating with patients, you need not know everything. So where and what you're going to do gives you a clue and idea what you need. So that is another way. So it's not perfect, but you can get it to a better level by doing this. Okay, hope I have satisfied or answered Dr. Shanmuga Sundaram's query. There are a few more questions on the chat box. You could go down there. Language. A terminally ill patient says, I won't live longer. How to handle? These things will come in our next session, Mukta, I think. As I keep telling you, I won't break the ice of every session. You all have to have the charm of every session. So you have one more session with Mukta who will take us through the nitty-gritty of things. Today is only introduction, okay? So the cherry on the cake is going to come in the next session. Next one. Is it appropriate to hold hands? Yes, definitely. That is what? Touch, feel, telling. Again, there you have something called, sorry Mukta, I'm taking there's something called as personal space and general space. You should first get agreement from the patient. You should gain rapport. Then, because some patients may feel offensive when you just directly go touch them also. So that little thing, Mukta will highlight and take you all through a little bit more. I'll read the next question also. What is that? During an in-person consultation, if a patient breaks down, we can show empathy by the touch of hand and being there and letting them cry. But in a telemedicine call, if this happens, what can we say to show empathy? Okay, Mukta, I'll give it to the person who can deal with it before I speak.
No, ma'am, actually, you are way more experienced than I am in all this.
You go ahead, then I will add on.
Yes, okay. So the first question, I mean, of course, touch is one of our most powerful tools in palliative care, I feel. And of course, taking their permission is very important. And this is something that you might need. You need not always. It's not always verbally asking them for permission. You get a feel of the person's personal space, right? So as long as you know that you're not invading, that's fine. And I have had many of my most rewarding conversations and communication with patients has happened with just to give you an example, there was this old lady who had come from an old age home. Yeah. And the old age home had sent her to our center. And all I had to do for her, and she had this very cheerful facade. Yeah. She was this, as if she didn't have a care in the world. All I had to do was I went near her and she was sleeping, like lying on the bed because she couldn't sit up. She was awake and I just had to do this and she broke down crying. All I did was I just kept a hand on her head and she just broke down crying, and it was just it was so moving to see what a simple touch could do. And she just opened about everything, about her physical complaints, about her emotional complaints, about how she felt so isolated and she didn't know what was going to happen. Everything just came tumbling out like that. So touch is definitely a very important tool. We of course have to use it very carefully though. It's not something that to be taken lightly and just, uh, not like that, definitely. And of course, the patient's comfort is going to be very important. Only if the patient is comfortable, you do it, otherwise you don't. Secondly, in a telemedicine setup, see, again, the same thing. Whenever there are these practical limitations, we have to work around them. We have to take into consideration that it's not going to be perfect. There are going to be these limitations, and then in spite of the limitations, do our best. So I might not be able to use touch, but then what else can I use? In terms of non-verbal, obviously my facial expression is going to matter if it's a video call. My words are and here it might have to, which is why I call it a skill. You might have to practice. You might have to practice what words to use, how to use them in such situations. You might have to have responses prepared to begin with. It might sound, you might feel like, oh, I'm rehearsing and saying dialogues, but to begin with, you will have to have these things prepared in your head so that it can start coming naturally and fluently. Like, what do I say to a person? Ma'am, you were saying something?
Totally, exactly.
Yeah.
I'll give another example as Muktha gave. See, nowadays, all of you, when you go for interview or things, you all prepare and rehearse. We also teach candidates stand in front of the mirror and speak. Okay, because then you will know whether your verbal cue and your word are matching. Okay, and then with telemedicine answer, what I would say is first accepting. So in the session today, Mukta did mention. First, you tell that yes, I can totally understand. It is not an easy situation for you. Anyone in your place will take it like that only. So tell like that, so that just those one few words will make a big change, because till then they might not have heard anything like that. So just telling that it is just, I can totally understand that your situation is not simple. It is not easy to handle. So that is why. So I can try and see. There also, I will try and see is different. I can try and see in what possible ways I can be of help to you. See, I will do, I can try and do. These and all, no? When you tell it casually, it may not have a big deal of difference. But when the person on the receiving end is in an emotional bottommost part of earth, then it will matter. So that those are important things. And then regarding the previous one, regarding handhold, first thing is that you can just go sit near the patient, which will give you an idea whether receiving, not receiving, whether is it taken in a nice way or not. So everything counts. So I hope there is a chance for the mobile patient to interpret it wrongfully, even though it's important, but I feel gender. Exactly. I was also about to come to that.
Of course.
Of course. That is why I said about personal space in the first instance itself. Okay. Otherwise, so there also it's not harmful. See, because you're only getting an idea or cue. Okay, there is, for that I'll just tell you. So when I said no, when you go sit, not on or next, just sit, no, the patient may be in the same state or move back. Okay, those are the cues. When you go sit, if the patient is moving back, it's a cue that, oh, they are not very comfortable. If they don't do any sudden jerky movement, they are okay. Then that is one step. Go little by little. See, these are all common sense things. How and what you will do in that situation. So again, I say all of you are experts. Okay, no need to teach something which is very easy, but We are trying to tell you because palliative care as such, no, is a sensitive and specific situation. Anyone in any life-limiting or life-threatening condition will not be the same as someone like everyone's routine. Morning, I get up, run, do all this, go. If someone is doing that as a routine, and suddenly one day everything changes, how will they be? So that is what is there. So we have to keep in mind. I think we'll go on to the case discussion and then come back. I can be brutally honest about my feelings and emotions when I am not in person taking or seeking help. I feel it helps being more frank. To begin with, sensitization of genuine patients to be better with telling. So these are all, no, these are all little things which you have to take individual case into consideration and that particular patient. That's why rapport and things are important. See, this telemedicine is something better than nothing. There are rural places where they have not seen a doctor. Always no simple tip I'm going to tell you. You can, this is a universal statement. Anyone, if I give you half a cup of tea, some may think, oh, I've got only half cup. Some may think I've at least got half a cup. So take every positive from everything and then try to build on it. And every one of you can do it. These are all the tools and tips that we say to build up those things. So this telemedicine is something which has made access possible for someone who did not get at all. So think if they are able to have a telemedicine and do rather than having no medicine contact at all, how will it be? That is what I would say. And there are difficulties, but they could be overcome also. Okay, we'll go on to the case discussion and come back for it.
Case specialist Dr. Anjana Sina. Welcome, ma'am.
Good evening, all. Hope I am audible.
Yes, go ahead.
So I'll be presenting the case of a 55-year-old female patient who was diagnosed with adenoid cystic carcinoma of tongue. So the patient presented with a complaint of wound on the left side of the tongue, which was there since 1 month. History of illness: the patient noticed a swelling in the left side of tongue 6 months back. The patient was initially, the swelling was initially smaller and gradually increased to the present size. She did not seek any medical help as it was asymptomatic. 1 month back, she noticed an ulcer over the swelling and took Ayurvedic medications for the same. She did not find any relief with the medication and was then referred to our department. There were no complaints of numbness or paresthesia in the region. There was no bleeding or discharge reported from the swelling. There was also no history of trauma. Patient gave history of hypertension and she was under medication for that since the last 6 years. On examination, the patient was febrile. The vital signs were all within normal limits. On extraoral examination, on inspection, the face appeared symmetric. Mouth opening was normal. No significant cervical lymphadenopathy was noted. Intraoral examination, on inspection, a well-defined swelling of size approximately 2 into 1.5 centimeter was present on the left lateral surface of tongue towards the tip. An ulcer of size 0.5 into 0.5 centimeter was present on the mucosa overlying the swelling. There were no bleeding, discharge, or visible palpations. On palpation, the swelling is tender, firm, and mobile. No bleeding or discharge was also present on palpation. On examination, investigation, an ultrasound scan was done, which showed a hypoechoic lesion on the lateral and dorsal part of the tongue. There were no calcifications, no significant cervical lymphadenopathy. We also did fine needle aspiration, which yielded thick blood-tinged mucinous material, but the histopathological examination was inconclusive. Routine blood examination was done. It was normal. Incision biopsy was performed. Histochemistry was also done, and which led to the diagnosis of adenoid cystic carcinoma. The patient was actually referred to regional cancer center, wherein the excision of the lesion was done along with a radical nerve resection. Psychosocial aspect: she was a housewife. Her husband was a daily wage worker. They had 2 children, and they belonged to low socioeconomic status. Her main concerns were affording medical treatments and associated costs, balancing treatment with maintaining household responsibilities, the impact on physical functions, especially the speech, and also the fear about the future. To summarize, a 55-year-old female reported in our institution with a chief complaint of wound on the tongue for the last 1 month. She had noticed an asymptomatic swelling on the same side 6 months back, and no specific treatment was done. 1 month back, she noticed an ulcer and took medications for the same. It did not relieve. So she came to us. An intraoral examination revealed a swelling of 2 into 1.5 centimeter left lateral surface of tongue, which extended towards the tip. And ulceration was also seen of size 0.5 and 0.5 on the surface of the swelling. The swelling is firm, mobile, and non-tender on palpation. No significant cervical lymphadenopathy was noted. No history of paresthesia was given. She was hypertensive and was under medication since the past 6 years. An ultrasound scan was done, showed hypoechoic lesion on the lateral and dorsal part of the tongue. There was no significant cervical lymphadenopathy. Final aspiration was done, which was inconclusive. We made a differential diagnosis of a minor salivary gland neoplasm. The possibility of a benign connective tissue neoplasm was also considered. Routine blood examination was done, incision biopsy, immunohistochemistry was done, wherein the diagnosis came as adenoid cystic carcinoma. Patient was referred to the regional cancer center, wherein excision of the lesion with radical neck resection was performed. So the discussion point, how to ensure that the patient fully understands the diagnosis, including the nature and the seriousness of the condition. How to provide an honest and realistic information about the prognosis, including the survival rates and potential for recurrence. And how to communicate to the patient, balancing hope with realism, ensuring that the patient is prepared for various possible outcomes. Thank you.
Thank you very much, Anjana. Mukta, you could just see, like in this, no, the initial part of the discussion alone we can do. Into the nitty-gritty stuff, as I said, which we will see in our next session, we can go ahead with that. But if you could go ahead and start off, and then we can see, Mukta.
Yes. Firstly, ensuring whether the patient has understood and what they have understood. The answer is pretty simple. Ask. Ask them what they know. Let them talk and you listen. And I think you will get a lot of idea about whether they've understood the seriousness, what have they understood about the diagnosis, all of it. And even when you are giving information, like I said, always keep, like, it's not, you don't give information at a stretch. You speak, you stop, you ask them whether they've understood, make them tell you what they've understood. And that is how you keep going, like step by step. But always make them tell you what they've understood so that you can clarify wherever required. Especially in such cases where, you know that they don't have an educational background where they will know about certain things, and that is where that summarizing, asking again and again repeatedly, ensuring that they've understood is going to matter a lot. About the second thing, I think the balancing hope with realism, some of it is definitely, like ma'am said, some of it is clarified today, but we will be speaking about how to deliver bad news in the coming session. So I think it will make it more clear then. Ma'am, do you want to add something to the first question? Ma'am, I can't hear you. I think you're...
Sorry, dear. I thought I unmuted. I unmuted myself again. The thing is that, see, first today's discussion, main thing is to, like the example case what Mukta gave is very common. Okay. As I say, we see all type of patients, maybe 50-50 educated, non-educated. Sometimes educated, more confused because of Google. Google helps and Google troubles. Okay. So don't be judgmental and don't think that. So today, main thing what you have learned, no, how to gain patients' confidence, how to gain patients' rapport. So that is what, how to ensure that the patient fully understands. First, make sure that they are comfortable and and willing to talk to you. So that by your meeting with them and the way you speak, what you speak, how you speak, that is the important thing first to gain their confidence. Then what you tell. So for what Muktha said, no, normally we say there is a mode called ask, or there's a mode called tell. See, sometimes no, we'll just keep on going telling. I will tell you, listen. That some may not like, may not be right also. Next, just ask that also. So that we normally say ask, tell, ask. That is the strategy to be followed. Basically, what ask, what, how are they, what is it? Like ask by open-ended questions. Then tell your response in a clear, simple, non-jargon use method. Then ask them to tell what you said in their own language. Okay, I might have told something in big sentences because I'm used to doing it on a daily basis, that being my bread and butter. But they may not be like that. So ask them to tell them, don't worry, you repeat whatever I said, how much you have understood. So that will give you an idea, because sometimes what you have said might not have gone past few centimeters. So only if you ask them to tell what they have understood, you'll know that you may have to come back and start from beginning. So ask, tell, ask. That is the strategy to be followed. So by doing that, you will also make sure that what you've said, what you've got, and what you've told is right, and that will help you in conveying anything, diagnosis or prognosis. So prognosis itself, they may not understand. Staging of the disease, that they may not even know what it is. So those things. So main thing is that the do's and don'ts, how I do, what I do is what. So this patient, see, because like from when she came, she did not even think what it was. It was a coincidental finding. So how was she, and how did you, just tell, how did you manage? Did you feel that before this session today, what you did was okay, or did you feel you could have done better, or whatever it is? Just tell us how you managed and what was your feeling.
Hello.
Yes, go ahead.
After this session, I feel that I could have done a little better, but
no worries.
Because the patient was really not expecting this. She thought that it was just an ulcer. Even to tell her about go for a biopsy was very difficult, because I felt that there is a taboo with this biopsy word itself, because people tend to be very afraid. So I felt that when we said that itself, she was really frightened. So from there, we managed to actually tell her very not lightly, like how ma'am, it
No
was
worries,
very difficult.
That is why. How did I start? Like as soon as Muktha finished, it's what did I say? It is a sensitive, specific, different situation.
Yes.
See, someone comes for fever, someone comes for biopsy. Are those two same, or someone comes, for example, if it's a caries in the mouth, one dental caries and one ulcer, are they those two same? No. So these sessions are mainly there to help you and enhance your skill. So the main thing I would say, take home from this session means, I'll say, start smiling. Okay, nothing wrong. We can all develop. Yes, please go ahead.
Can I ask a question?
Yes.
In some patient with some real risk more than the benefit, we keep explaining to the patient and the relatives about the prognosis, diagnosis, everything in the simplest of the terms for almost 10 minutes, and they listen carefully. Then at the end of the 10 minutes, if we ask them, is it okay? Then they will say, they will ask, "பயப்படுறதுக்கு ஒண்ணும் இல்லையே? There is nothing to fear, is it?" That's the
That means
question
they
they
have
will
not
ask.
understood. So
How to face it? This is a common situation we normally encounter.
no, that's why I'm telling. What did I say? Ask, tell, ask. So don't keep on going for 10 minutes. So first few sentences you say, is that what have I got your query correctly, Dr. Sundaram?
Yeah.
So
Thing
that is
is,
why
they,
take your time. See, always these type of things in one sitting, you cannot convey everything and do everything. At least 2-3 sittings, or that is 2-3 consultations can be in a same day. Like sometimes what we do, we'll talk to them in the morning and they'll say, no, this is all too much, nothing went in. So okay, after 2-3 hours, if you can come, and I can also find time, I can come back to you and do that. So that's all. Doing all this, no, in your next session, you are going to see there are so many strategies which you will be told about how to deal with it.
okay.
So that's
Thank
all.
you.
That difficult, as Muktha said, no, you have 2 important topics in your next communication session. Breaking bad news. That is what it is. Is that right, Dr. Sundaram? Mainly something difficult, how to tell and how should I tell?
Yeah.
Next, another important thing is called as solution. Both will be dealt completely in your next session.
Okay, ma'am. Thank you.
Just one thing to add, ma'am. In this question that Dr. Sundaram just asked, it is also they are basically seeking reassurance.
Yes,
It's an emotional response.
correct.
And you need to address the emotion at that point. You just need to validate that they are worried.
That's all. Will I be all right? Will I be
Yeah,
all right?
the problem is if we acknowledge their emotion and but they won't give the consent for surgery or treatment. That is the issue. So if you say there is some real danger is there, I can understand what you are thinking. What they have in their back of mind is whether the patient will die or not. What is the risk of death in such case if you do surgery or any procedure?
You have to tell the truth there, no? What is your opinion?
That's what. See, it's a very difficult situation. Most of the time, if we tell the truth, they will just not accept or not give consent for your procedure, and that is the problem. But at the same time, they would want the correct treatment also. So it's a catch-22 situation there.
If I can know what, where and what do you practice?
No, I am a surgical oncologist. I am the professor here in Tirunelveli, government hospital.
Okay.
So
no worries. We will like in our next session, we can have more discussion on it because we will be telling you ways and means for that also.
Okay, thank you.
Most welcome. Now, Muktha, go ahead. And the main thing what you were telling is they are looking for assurance, but they're only one point from today, I will say, no false assurance. Give practical, realistic assurance. That's what was told today. Muktha, anything more you want to add on to that, please do, or even...
No, just that.
So,
just that. Yeah.
So that is what. So that is why you have to make sure that they are in a receiving end. So there is something called as denial. Okay, which will be very, 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 very. I'm putting so many very because it will always be there. That denial itself will change in your third meeting. As no, only by seeing patients, I'm telling all this. Okay, it's not, I'm not picking it from somewhere in the open air, out of the air, I'm not picking. Only by seeing patients, you will see their emotion change, see the personality change on your third meeting. They will come up, doctor, tell the truth. Okay, so that has to come from that side. It will come. They know what it is, but they are trying to get something what they want or what they are willing to hear. This is all human beings' attitude and nature. There's nothing wrong with anyone. So it is just transformation. That's all. Nothing more than that. And third day they will come and tell. Please tell. So your whole situation will change and you will be able to. Muktha, go ahead and add on before I don't think there are any more fresh questions. I've just had a look. Muktha, anything else you want to add on, please do, and then we can pass it on to Sangeet.
Yeah. No, ma'am. I think much of it will be clarified in the coming session also.
Exactly. Okay. I'll pass it over to Sangeet then.
Thank you, ma'am. Thank you, Dr. For the wonderful session. Thank you very much. Thank you, Radha ma'am, for facilitating the entire session. Thank you all. Thank you for joining. Let's see in the next session. Thank you. Bye.
Thank you all.